Mr. Edwin Chandraharan, our eminent international speaker today, President SBSI, Professor Neelam, will be joining shortly. Chairperson of the today's session, Professor Reva Tripathi, Chair of the Committee for Prevention of Stillbirths during the intrapartum period, Professor Aruna Nigam and her team, members of the Stillbirth Society of India. As part of the Stillbirth Society of India's mission, today we are focusing on a very important cause of stillbirths. It is said that 50% of stillbirths in our part of the world occur during labor, which is a sad and very pertinent reflection on our obstetric skills or the lack of it and the quality of care that we provide during labor. It's my honor and pleasure to introduce Professor Aruna Nigam as the chair of the committee and her team. She has done a lot of work in training and improving obstetric skills of students, both at the undergraduate and the postgraduate level. And she has a dedicated website and video lectures for this team. She is the editor-in-chief, Pan-Asian Journal of Obstetrics, national corresponding editor, Jogi, editor of 3 books, executive editor of Indian Journal of Medical Specialties, more than 200 publications with a high citation index, recipient of Ethicon Fellowship for Endoscopy, and for her paper she received on endoscopy, she received an award. She's recipient of Women Scientist Award and an executive member of the Ethical Committee, Medical Education Committee, with a special interest in gynecological endoscopy, gynecological oncology, high-risk pregnancy, and medical education. It's a pleasure to have her on our team and heading this committee. We have Dr. Jogati Unni as the secretary. She's a senior consultant for Nandi's Hospital Foundation, Hyderabad. She's the labor ward lead and unit head, and her areas of interest include, labor ward protocols, and she's worked a lot on placenta accreta spectrum and perineal tear. We have Dr. Sridevi as senior consultant again from the prestigious Fernandez Hospital. Dr. Sumedha Sharma, it's a pleasure to introduce her. She's also a an alumni of our medical college and my student. And I'm currently working as assistant professor, HIMSR, Delhi. Dr. Arfa Anwar, she's working as an associate professor with Dr. Aruna Nigam. Dr. Deena Aisha is also an assistant professor. Dr. P.O. James, he's a lead consultant, maternal fetal medicine from Trivandrum Medical College, and also an assistant professor at Ernakulam, Kerala. And we have the youngest member of this team, Dr. Asma Bashir Kande, also working as an SR at HIMSR, Delhi. I have this task of introducing Mr. Edwin Chandraharan. He is currently working as a director, Global Academy of Medical Education and Training Limited. He has a wide experience at St. John's College, Jaffna, at Cardiff Law School, Kasturi Medical College, Manipal, and also the University of Colombo. He has very important books to his credit: Obstetric and Intrapartum Emergencies, High-Risk Obstetrics, and also a book on CTG, which has made a landmark change in the interpretation of CTG from the common approach that we were using earlier to a physiological approach to its interpretation. I'm also pleased to inform you all that he is the one who has worked extensively on past disorders and developed the triple pre-procedure for placenta percreta. He has been working passionately for reducing intrapartum related hypoxic injuries and perinatal deaths, and he has worked for the last 15 years, and because of that, he's been awarded with the BMG Clinical Leadership Award for ensuring a reduction in emergency cesarean sections and decreasing hypoxic ischemic encephalopathy through implementation of physiology-based CTG interpretation with the use of fetal ECG. He's a great researcher with more than 182 research papers to his credit, number of projects, and citations running in thousands. I now hand over the proceedings to the chair, Professor Aruna Nigam.
So now we are starting with the main session, and you see the intrapartum part of the pregnancy is the most important part, and when all eyes are on the obstetrician for a healthy mother and the baby. But this is not the situation every time. And sometimes every one of us has faced this situation when we are having a stillbirth on our hands. Then what? What went wrong? We did the monitoring. Our continuous monitoring was there. CTG was going on. What went wrong? How to face the parents? How to face the mother? And what next? These are the three important points which we have to focus whenever we are talking about intrapartum stillbirth. So we try to take two of these topics, the CTG monitoring, and we have none other than Dr. Edwin for the same. And for fetal autopsy, we have Dr. Manisha from Lady Hardinge Medical College, who is a professor. So to start with the session, I would like to invite our chairperson, that is Professor Reva Tripathi. She was a past HOD, Hamdard Institute of Medical Sciences, and a former HOD of Maulana Azad Medical College, former Dean of Delhi University, and presently she is working as a senior consultant in Sitaram Hriya Institute of Medical Sciences. So welcome, ma'am. The other chairperson is Professor Neelam Aggarwal. She needs no introduction because she is the only person. She, Dr. Tamkin, all are behind the establishment of this society. So she is currently working as a professor and head at PGMIR Chandigarh. So welcome, ma'am. So we just, without any delay, we start with the session, and already we have an introduction of Dr. Edwin. So Dr. Edwin is going to talk on prevention and early detection of chorioamnionitis in labor. All is yours, sir.
Good afternoon. And first of all, Ayesha, thank you very much for your kind words and also for inviting me. And Aruna and the rest of the team, you are doing a very, very important role as obstetricians to improve outcomes for not only babies, but also for women and families. My task is to talk about prevention and early detection of chorio. So let's go and look at chorioamnionitis. Let me get my pointer first. Okay. So chorio, we know that is inflammation of the placenta and membranes. That's what it is. So if you really want to prevent chorioamnionitis, we then need to think of how do we prevent the bacteria entering into the fetal compartment. The second issue is, if you have any risk factors that increase the risk of chorio, we need to prevent those too. And in terms of early detection of chorioamnionitis, we need to be thinking of recognition of fetal inflammatory response on the CTG. We need to be thinking of signs and symptoms in the mother. You can see that if chorioamnionitis is a disease of the baby, often you won't have signs and symptoms in the mother. And this is the problem of our guidelines. We want to detect chorioamnionitis based on maternal pyrexia and maternal tachycardia, which are not going to be there in chorio unless the inflammation starts in the mother, like mother has the source of infection, or in very late stages in fetal chorioamnionitis. So let's look at the pathogenesis first. So you're having bacteria, they are going to enter into the fetal compartment somehow. And just like adults, those bacteria, they are going to multiply and then they release toxins. And this is why, just like adult sepsis, babies get unwell. So what I was saying is prevention, entry of the organisms into the fetal compartment and recognition of risk factors and early detection. That means we were thinking of how do we recognize features of fetal inflammatory response on the CTG trace, and how do we recognize features of maternal inflammatory response? And I think this is where we came to. So the bacteria, they are entering into the fetal compartment. They are going to multiply. They are going to invade the tissue just like in adults, and they are going to produce toxins. One of the important toxins is lipopolysaccharide, so LPS, and especially the gram-negative organisms they produce it from the capsular toxins. And then you have the host response. And what do we do? Whether you are an adult or baby, it doesn't matter. We fight the infection. So we are going to have inflammatory response, cytokines. So if you are thinking of fetal damage in chorioamnionitis, it is multi damage because they have to deal with the bacterial toxins. They also have to deal with their own response. As we know, baby's brain is not fully developed. They don't have a properly developed blood-brain barrier. And therefore, if you have intense fetal immune response to bacteria, those immune, it's not the bacteria that enters the brain and damages the brain. It's the immune mediators that they damage the brain. So if you see the babies, the main port of entry of the bacteria is through the lungs because they are breathing. We all learned in medical school that babies have fetal breathing movements. So when they are breathing the amniotic fluid in and out, the bacteria in the amniotic fluid due to ascending infection, they go to the lungs and they cause congenital pneumonia. And this is the reason why, once it becomes a systemic infection, remember we learned in medical school something called SIRS, systemic inflammatory response syndrome, which is a part of sepsis. Babies have the same. It's simply called FIRS, fetal inflammatory response syndrome. So what happens to them? Just like you and I, they get multi-organ failure. So chorioamnionitis, if you think about it, is worse than hypoxia if you are a fetus. And sadly, we miss them because we are looking for changes on the CTG for hypoxia. We are looking for decelerations. But actually, they don't have hypoxic changes. Why would they show you decelerations if the umbilical cord is not squeezed? Why will they show you deceleration if there's no placental insufficiency like growth restriction? So our guidelines will fail them. And that's why physiological interpretation of CTG is so important to save these babies. So you can see lung injury. And this is the reason why, if those of us who are senior, if you look at your experience, most of the time babies are born with severe chorioamnionitis with normal Apgar scores and normal cord gases. It's only when they are breastfeeding, they become gray, they collapse, they go to the neonatal unit. That's because once you clamp the umbilical cord, they have to use the lungs to breathe. And if the lung has or got damaged due to congenital pneumonia, you cannot help them. That's why they have normal Apgars, but they collapse afterwards because they are not having hypoxia. And again, myocarditis is very, very important. Just like in adult sepsis, we all die if you get sepsis due to myocarditis. Our heart fails. In the same way, if you are a fetus, if your heart is going to fail due to inflammatory mediators attacking your myocardium, you're going to have a slowly reducing baseline. So if you have neuroinflammation, this is why you get neonatal encephalopathy, NNE, brain damage. And infection can damage wide areas in the brain compared to hypoxia. So let's look at how the bacteria enters the baby. One way is the mom is having infection. So it can be pneumonia, gastroenteritis, pyelonephritis. It doesn't matter what the infection is. So what happens? The bacteria is in the mother's compartment and they enter through the placenta. It's the hematogenous spread. In a way, if you are a baby, this is the kind of infection you want. If you have to have one infection and if you have to choose, as a fetus, I will choose this. You know why I will choose this? Because the mother is having the infection. So she's going to have tachycardia and pyrexia because the bacteria is in her compartment. So my obstetrician will pick this up because mama will show tachycardia and pyrexia very early. And if my obstetrician gives antibiotics, these bacteria, they get killed. So my mother's temperature gets better. My mother's pulse rate gets better. Bacteria gets cleared from the mother. She improves, I improve. So if you are a fetus, if you have been forced to choose one infection, choose this. But the commonest infection is not maternal inflammatory response. The commonest infection is the ascending infection. Because if you think about it, when I was inside my mother, if I just look down, her vagina was full of organisms, because it's just a continuation of the thigh of a woman. And therefore, you'll have multiple bacteria in it. And therefore, the ascending infection is very common compared to hematogenous spread. But in an ascending infection, my mom is not going to show any signs for you because it's not her infection, it's my infection. And therefore, I'm the one who is going to show you tachycardia and pyrexia. But you will be looking at the mother. And you can see anatomically how close the rectum is from the vagina, especially if the woman is multiparous. Almost there's no perineal body. And therefore, these bacteria which live in the rectum, GBS, E. coli, they can very easily get into the vagina, into the lower vagina. And in that case, you're going to have fetal inflammatory response, not maternal inflammatory response. So if you're going to look for mother's pulse and mother's increase of temperature, we will miss this case. So this is your microbiology spot diagnosis from medical school. The top one is GBS, other one is E. coli, gram-negative rod. And we think as obstetricians, these are the common organisms. And we screen for them. But that's not true, because if you look at the human vagina, the higher you go up in the vagina, there's less oxygen. And therefore, on top of the vagina, you don't have E. coli and GBS because they are aerobic organisms. In an anaerobic organism environment, you only have ureaplasma and mycoplasma. So they are going to start colonizing the upper vagina. But if I'm a fetus, they are the ones which are close to me to enter, not the GBS and E. coli, which are in the lower part of the vagina, because they need oxygen. And oxygen is only present mostly in the lower part of the vagina, which is exposed to the atmospheric oxygen. And that's why I'm sure in India as well, but in the UK, when we screen for group B streptococcus, GBS, we do low vaginal swabs, not high vaginal swab. If you're doing high vaginal swab for GBS, you will miss them, because you will miss all the organisms, because ureaplasma and mycoplasma, that they need transport medium, because they are anaerobic organisms. The moment you expose them to oxygen, they simply die. So the lower part of the vagina, you get GBS and E. coli. So if you want to prevent chorioamnionitis, please take a low vaginal swab, not a high vaginal swab. But please remember, just because the low vaginal swab is negative, no growth, it doesn't mean that the baby is not going to get infected, because the anaerobes are very, very close to the baby. And they are the ones who cause most of the infection. But as human babies, we have been over 2 million years of evolution. We knew that, I knew my mother is going to be quite dangerous for me in labor, because even the moment the cervix opens up, all these bacteria can come and infect me. So what did I do as a human fetus? I was clever. I had mechanical barriers. So I had a amniotic membrane to protect bacteria from coming in. I had a thick cervical that kept the bacteria away. And to hold the mucus, I had thin, long cervix, so that the bacteria were kept so far away in relative terms. So you can see why short cervix leads to preterm labor due to infection. When the cervix becomes shorter, this mucus plug cannot be held inside, so it comes off, it falls off. So there's no mucus preventing the cervical canal, blocking the cervical canal. And not only that, these bacteria, they are very close to the fetal compartment, and the baby can get infected. We also had immunological barriers. For example, passively transferred antibodies from the placenta. So my mother, during pregnancy, kept on giving me IgG antibodies. from her system to help me to an extent. Then you have amniotic fluid phagocytes. So all of us were lucky as human fetuses. We had neutrophil macrophages just waiting in the amniotic cavity so that any bacteria that tries to come, it goes and gobbles it up, eats it up. So you have got, you and I as fetuses, we had natural defense mechanisms. We also had immunological mechanisms, both mechanical and immunological. And the other thing we need to remember if you are trying to prevent infection is that going back to microbiology, our professors in microbiology in medical school taught us that there are 3 important factors that determine how severe the infection is: the virulence of the organism, our response, and bacterial load. So this is why the vast majority of babies with chorioamnionitis do well. Because if the organism is not that virulent, if the dose is very small and the response is good, they escape. But imagine if you have GBS, it's a virulent organism, it's very toxic. And if you are preterm, your immune response is not good. And if you have a larger bacterial load, it can cause you problem. So again, as a fetus, you see how much of defense mechanisms we have been blessed with in intrauterine life. But you know what Edwin Chandraharan does? Edwin Chandraharan, the obstetrician, forgets about human evolution. You know what he does? He has invented a procedure called membrane sweep. So he's going to take a broom, sweep all these bacteria through the cervical mucus. And the baby is telling me, come on, Edwin, which medical school did you go to? Did you really pass your MBBS exam? Or did you really buy your certificate from eBay? Because how is it, Edwin, that you can push all the bacteria inside and you sweep it and you send the woman home for incubation? And you learned in medical school, load of the bacteria is one of the important key features of evolution, of infection. So in 200 years ago, when James Hamilton did this technique, membrane sweep, we can't blame him, because you know why? 200 years ago, there were no prostaglandins synthesized in the lab. So the only way you could make women to go into labor, if they are going post-term, is to sweep the membranes to release prostaglandins through mechanical stimulation. So even today, in some parts of Africa and Asia, in rural areas, if we don't have money to buy prostaglandins, it's okay, because we are weighing the risks and benefits. But in cities in India, in the UK, to do membrane sweep, when you have prostaglandins readily available in tablet form, gel form, and in slow release pessary form, this is not acceptable in modern obstetric practice, because the success rate is the latest Cochrane systematic review, only based on very poor quality evidence, is only 21%. If the success rate is 80-90%, then you have a risk-benefit analysis. So to achieve 21% modest success rate, we are putting the bacteria inside and then sending the woman home, which is very, very unfortunate. So you can see, I'll skip through because of time. What we are doing is we are disrupting the cervical mucus. We are releasing local prostaglandins. We are causing bleeding due to membrane sweep, which is blood is a good culture medium. And we are just introducing large amount of bacteria. And if you ask me, Edwin, where is the evidence? This is the study we published last year. We looked at six years of confirmed cases of chorioamnionitis and funicitis. So it's confirmed, there's no doubt, histologically confirmed. And when we looked at it, you see 87% of women of placenta which showed evidence of chorioamnionitis, 87% of them had an artificial separation of membranes or membrane sweep 24 to 48 hours before. It's not rocket science. It's easy to understand. In women who had got emergency sections and babies went to neonatal unit due to infection, 95% had a membrane sweep 24 to 48 hours before. That's the time of incubation period. And for women who came back with wound infection, again, you can see over 80%, 85% had a membrane sweep before 24 to 48 hours. So please, if you're trying to prevent chorioamnionitis, to prevent intrapartum stillbirths due to infection, think before you sweep and ask yourself, am I doing the right thing for the woman and the baby? So if you look at us as a fetus, we have defense mechanisms, neutrophils. But when the bacteria come in, this is where they are. They release metalloproteinases and your toxins and proteolytic enzymes to digest the membranes because they want to go inside. So when the woman comes to us with SHROM, rupture membranes, remember the bacteria is already inside. It is useless giving prophylactic antibiotics when there's established infection. And that's one of the problems we have faced in the past. We only give antibiotics when the membranes ruptured. Ask yourself, why did the membranes rupture without contractions when there's no pressure? And that's because these bacteria, they come and release metalloproteinases. The neutrophils, they go through chemotaxis. They release proteolytic enzymes to fight these bacteria, but they end up damaging the membranes. So it is only when the baby is now inhaling all these fetal breathing movements, all the bacteria in the lungs, and the baby gets fetal inflammatory response, baby's temperature is going to go up, baby's inflammatory response is going to go up, but it's only in late stages when that inflammatory response comes to the mother's compartment, you're going to have tachycardia and pyrexia. So in early stages, you'll only have leakage of amniotic fluid and a 10% rise in the baseline heart rate on the CTG because the baby has temperature. It's a fetal disease. The next thing is, before we go further, meconium. So you might ask, so what's the big deal, a bit of meconium? The big deal is this. The meconium we know is green because it has got bile salts, bile acids. And what do? Bile salts and bile acid cause emulsification of proteins. But fetus also has carbohydrates, proteins, and fats. And therefore, if you put meconium around you, it's going to cause emulsification of your fat, digestion of proteins, and inactivation of your phagocytes. And also, imagine putting vernix caseosa and desquamated epithelial cells and langur hair into your lungs. So it's going to cause an intense alveolar inflammation. And that is why meconium is dangerous. Your meconium aspiration syndrome, even in the Western, large Western country with lots of money, there's no treatment. Only treatment is ECMO, artificial lungs, because it is not bacterial pneumonitis, it's chemical pneumonitis. So when they looked at studies on how the meconium affects the baby and the growth of E. coli and GBS, it's very, very simple. When they put little bit of, normally in a clear amniotic fluid, you can see E. coli doesn't grow if you put E. coli inside because of the macrophages that eat up E. coli. So they don't grow. Whereas the GBS, you can see, after about 4 hours, it forms colonies. And that's why it's a dangerous organism. We don't have, as humans, any protection against the GBS. We only have protection against E. coli. But the moment you start putting, this is a little bit of meconium, a thin meconium, it inhibits phagocytosis. And you can see E. coli starts to grow, even if you have a little bit of meconium. And then GBS multiplies really fast. And the thicker the meconium is, worse is the situation. So in the UK in the past, we used to classify meconium into thin, thick, that's all nonsense. Because meconium is meconium. You and I, when you eat your, say, a Rajasthan chicken curry, go and chicken curry, you might pass, if it is very spicy, loose stools. If you eat steak and kidney pie, you will pass thick stools. But it's stools, it's feces. In the same way, meconium is meconium. Just because it looks thin or thick, if you're a baby, it's bad news for you. And that's why take any meconium seriously, because they increase the risk of chorioamnionitis. And again, if you think of local effects, if you have meconium all around you, it can cause umbilical cord spasm. If you look at postmortem reports, you see conditions like erythema toxicum, the skin necrosis, because it's a digestive enzyme it has. And even cases of umbilical cord metabolism, destruction, necrosis has been reported. So we have local effects, but this is what we don't want to have in chorioamnionitis, because if you put meconium into your lungs, it displaces your surfactant. Even a term fetus can have respiratory distress syndrome, and you can have meconium aspiration syndrome. And you can see, because it's a chemical digestion of the lungs, the only treatment babies have, because the whole lung tissue is destroyed, you can't intubate and ventilate because there's no lung alveoli to absorb the oxygen. So let's now go for the next 10 minutes or so on chorio and meconium. So I'm getting bacteria inside as a fetus, I'm inhaling it, it goes to my lungs, I get congenital pneumonia. But I'm also swallowing it. If you eat a rotten Kentucky Fried Chicken Colonel's leg, you're going to have diarrhea. So when you swallow infected amniotic fluid, you're going to have fetal diarrhea. And that's why meconium is passed in chorio. Meconium and chorioamnionitis are very, very closely related. So the local and systemic effects are very important. So I'm going to release all the toxins. My temperature is going to go up. So if you increase your body temperature, your baseline heart rate is go up by 10%. And I'm going to have multi-organ failure, that is the fetal inflammatory response syndrome. And the problem is I don't have a properly developed blood-brain barrier like an adult. So all these inflammatory mediators, they are going to get into my brain. I've got neuroinflammation. And that is the problem. When you have neuroinflammation, your neurons are all inflamed. Their metabolic requirement goes up. Their oxygen demand increases. So if we allow contractions to continue in that case, without recognizing features of neuroinflammation on the CTG, then what is going to happen is these neurons want more oxygen. And that's why in sepsis, in adult medicine, we give oxygen immediately. Because if the tissue metabolic demand increases, if you don't give oxygen, they will go into anaerobic metabolism and produce lactate. And that's why the anesthetist keeps checking lactate in sepsis. Babies are the same. They're just like us. So if their neuroinflammation increases, if you don't give enough oxygen, they are going to develop anaerobic metabolism, lactic acid in the brain, which damages the brain. That's what you get neonatal encephalopathy. But please remember, continuing the contractions, it doesn't increase the oxygen. It reduces the oxygen. And that is why we need to be very careful about starting oxytocin, allowing contractions in chorioamnionitis. So the early detection of chorioamnionitis, if it is a fetal disease, we need to be looking for features of increased metabolic demand on the CTG. We are going to look for features of neuroinflammation and myocarditis on the CTG. It's only when the inflammatory mediators go into the mother's compartment, you are going to see maternal signs and symptoms of viral infection. And that's a very late sign. So let's work it out. So if you have increased metabolic rate as a fetus, if you have fetal inflammatory response syndrome, if you have end stage where your brain is having neuroinflammation and your heart is failing due to myocarditis, what features are we going to look for? So if your baseline heart rate, those of us who do physiological interpretation of CTG, we don't use baseline of 110 to 160 beats per minute for all babies because we know it's nonsensical. As the gestation advances due to parasympathetic development, as the baseline heart rate comes down due to vagal dominance, at 41 weeks, we cannot allow anything more than 140 beats per minute as normal. At 40 weeks, anything more than 150 should be abnormal. That's what the scientific evidence shows. So if I'm coming to you as a fetus with a baseline heart rate of 150 at 41 weeks, you cannot call me normal because my baseline heart rate is not appropriate for my gestational age. I have a problem. In the same way, during labor, if my baseline heart rate increases without decelerations, because if I'm having hypoxia, I will show you decelerations before releasing catecholamines to push up my heart rate. But if I'm having infection and sepsis, my baseline heart rate will go up by 10%. So I might come with you to your labor ward with a baseline of 120. After a few hours, I'm having chorioamnionitis. My baseline has gone to 140. If you're using guidelines, you will miss because the guidelines say 110 to 160 is normal. I am saying I'm not a guideline baby. I'm an individual baby. I'm not a part of a population for you to treat me like a population. My heart rate has gone up from 120 to 140. Ask yourself why. And then loss of accelerations because I feel unwell. I don't move, just like you and I in sepsis, we don't move. And I lose my deep sleep cycle. So the phenomenon of cycling will go from the CTG trace. And if you allow labor to continue, then I'm going to develop metabolic acidosis, just like in sepsis in adults. And that's the time you will start to see reduced baseline variability. So in chorioamnionitis, please don't look for variability to be reduced. That's very end stage. In hypoxia, it's different. But in chorioamnionitis, it's not about reduced variability. It's about looking for absence of cycling, sinusoidal and zigzag patterns. And at the end stage, when the myocardium gets inflamed, you have a step ladder pattern to death. And you can see why the standard guidelines miss these. Because when you give a baseline of 110 to 160 as normal, if the baby has come to you with 120 and increases the baseline to 140, it is considered to be normal. And the guidelines are asking us to look for big decelerations. But this is not hypoxia. This is infection. In infection, you don't get decelerations. The guideline doesn't tell you about cycling. The guideline doesn't tell you anything about zigzag pattern, which are features of neuroinflammation. And we end up missing this baby. So when we looked at our study, initially, when the baseline heart rate went up in the baby, there were no signs and symptoms in the mother. Then the CTG showed evidence of neuroinflammation, mainly absence of cycling and zigzag patterns. It's only after that 73% of women develop pyrexia at the very end stage. So it's very late stage that you're going to have pyrexia. But please remember, if it is only 73% getting fever at the end stage, that means 30%, even in severe cases of neuroinflammation, they don't get any symptoms and signs. And that's why these babies are missed by guidelines and they die. So if you look at scientific evidence, even if you have isolated intrapartum fever in the mother, the risk of cerebral palsy is 3 times higher. But if you have chorioamnionitis, the risk of cerebral palsy is 5 times higher. And it has been shown in many studies that chorioamnionitis increases the risk of cerebral palsy 4-fold. And if you look at 100 babies with cerebral palsies, 1 in 10, they didn't have hypoxia, they had infection. So this is a kind of checklist that we use in all the hospitals, now 30 hospitals in the UK, and about 30% of all hospitals in Spain and many other European countries, they are now using physiological interpretation of CTG, which involves the first step is to check whether this baby is fit to undertake the journey of labor. So it has got just 5 things to look for. Is the baseline heart rate appropriate for gestation? Do I have normal variability and cycling? Is the somatic nervous system well oxygenated? Is the placenta functioning well? Do I have any shallow or late decelerations? And in this case, what is the baggage the baby is carrying? So meconium, temperature, all are a problem for babies. So you're asking the question, is this baby fit to undertake the journey of labor? If the baby does not fulfill these criteria, then emergency cesarean section is the only way to avoid damage and death in these babies. Because if you continue labor, it's like in sepsis. Go to the ICU, and a woman is with sepsis, and she is having oxygen mask. Try taking the oxygen mask in the ICU and start taking a pillow and putting it on her face 3 to 4 times in 10 minutes for 1 minute each, and try continuing it for 5 hours. She would die and the family will come and sue you. So why do we treat babies any differently in utero? They're just like us. When they have sepsis, they need oxygen. Continuing contraction takes away the oxygen, and they are going to die or get severely damaged. It's no different to a woman with sepsis. So our study also found that 1 degree rise in temperature increases the baseline heart rate by 10%. All babies in our study, we looked for 6 years of confirmed cases of chorioamnionitis, increase the baseline by approximately 25 beats per minute. It's very important because 1 degree rise is about 10%. So if you're a term fetus, if your original baseline is about 110, 10% is only about 25 beats, which means if you are using a guideline that says 110 to 160 is normal, you are going to miss 43% of these babies with chorioamnionitis. Because in sepsis, you can't just push your heart rate so much. Whereas in hypoxia, you can, because there's a catecholamine response. So please keep that in mind. So you can see here, this is one of my medical legal cases. If they have used the tool that physiological guidelines are using, they would have found that the baseline at 40 weeks is not appropriate for gestational age, and easily to detect chorio and avoid further stress and deliver. But if you use a standard NICE guideline, the baseline, all these are for hypoxia. They are not even good for hypoxia, but let's say they are good for hypoxia. But they are going to miss all these infections. So you can see here, if you have chorio, the placental villi, we learned in medical school, one of the features of inflammation is tumor. Remember tumor, dollar, pallor. Remember those features of inflammation and functio lisa, loss of function, and rubor, redness, 5 features of inflammation, physiology, first year. So these villi are going to be edematous, and therefore you have reduced gas exchange. If you allow contractions to continue, you are squeezing the spiral arterioles, getting less oxygen to the baby. And imagine you do it in a pediatric ward. If you go and find a child with sepsis in pediatric ward and take away the oxygen mask and keep covering the mouth and the nose for 3 to 4 times in 10 minutes for 10 hours, and the child will die or will have severe brain damage, and you will be, and I will be sent to courts. Just because babies don't have legal rights, we should not be doing crazy things like this. Because we knew from long time ago, this is a paper from Donald Peebles in the British Journal in 2002, exactly 20 years ago. He showed that if you're a fetus A, that means you don't have any antepartum inflammation. You need a large dose of hypoxia to damage your brain. So if you don't have infection, you're okay because your brain neurons are resistant. But if you're fetus B, which is this one, where you have got chorioamnionitis before, even a small dose of oxytocin can damage your brain. So you can see here, if they have used the physiological guideline tool in this case, they would have picked up the baseline heart rate has gone up by more than 10%. They have said no cycling, and central organs for hypoxia point of view, they are okay, but this is chorioamnionitis, and there's a risk of meconium aspiration syndrome and deliver. And now in the 3 hospitals I'm working with, 12,500 births between them, we also added any features of chorioamnionitis just to help the staff in the middle of the night. So this is the tool they are using in hospitals where they have implemented physiological interpretation of CTG. And you can see this baby was showing them a zigzag pattern. They were continuing contractions because according to NICE guidelines, this CTG did not show many decelerations, and it was not a pathological CTG. And Letizia was from Italy. She did a fellowship with me for 6 months, and we published the first paper with 2,000 cases on looking at features on the CTG of clinical and subclinical chorioamnionitis, we should not be looking for decelerations. Absence of cycling is very, very important in chorioamnionitis. And we also showed that if you look at meconium in chorioamnionitis, compared to CTG features not showing chorioamnionitis, which is only 2% had meconium, you can see that's about 18 times increase, because meconium is strongly associated with chorioamnionitis. Presence of meconium can obliterate phagocytosis, increasing the risk of infection. On the other hand, if you have infection first due to fetal gastroenteritis, you can pass meconium. So if you see meconium, take it very seriously. It is chorio until proven otherwise. And you can see even the risk of neonatal admission is 5 times higher. And this is the reason why we have to be careful. Because when you have neuroinflammation, as the inflammatory mediators start entering the brain, blood-brain barrier and keep bombarding the brain, the neuronal metabolism increases, because that's sepsis, that's inflammation. Your metabolic rate increases. So they need a lot of oxygen to deal with it. But if you allow contractions to continue, or worse, you start oxytocin, we are actually taking the oxygen away when the baby needs more oxygen. So it's not rocket science that if you combine hypoxia with infection, if you look at scientific evidence, the risk of brain damage is 78 times normal. So you can see in this case, we are going to finish, sorry if I'm overrunning, just a couple of more CTGs. So you can see here, the baby has lost cycling. There is no quiet sleep pattern at all. If you are a healthy baby, you should show cycling. And here you can see the variability is everywhere. There's no quiet sleep, deep sleep. And they started giving antibiotics. And this is the problem, isn't it? This is what I was taught when I was a registrar by my consultants, to give antibiotics. Really? If you give antibiotics to the mother, bacteria are laughing at us. I mean, now I know why sometimes when I used to pass through the labor ward, I used to hear people laughing. I couldn't understand who was laughing. Now I know it's all those bacteria. They were laughing at me. Edwin, what crazy medical school did you go to? Because if you give antibiotics to the mother, it doesn't come to the fetal compartment to kill your bacteria. Because if the mother has infection, if you give antibiotics, it takes them off. If the baby has infection, nothing crosses the placenta in sufficient amounts to reach minimal inhibitory concentration. The only antibiotic that works is benzyl penicillin for GBS prophylaxis. It works in 70% of cases, because when you give it to the mother, it comes and knocks off those bacteria in the mother's vagina. It acts on the mother, not on the baby. That's why it's good. But the rest of the antibiotics, once you have a fetal infection, they are useless. And the bacteria are laughing because 22 years ago, this study was published in the British Journal. When they did research, they found erythromycin only crosses the placenta 3%, and they said there's limited transplacental passage. And some of the guidelines then recommended erythromycin. After looking at this study, I don't know how evidence-based medicine is going out of obstetrics. And as Aruna has said this morning, we are having all these sad cases because we are not improving ourselves. So here you can see interferons, interleukins finally attack the myocardium. Your myocardium, once it is attacked, myocarditis, you can't have a stable baseline. Baseline becomes wavy. And it is not surprising that the last organ that is going to fail is sepsis. And sadly, this baby died. But if they had used physiological interpretation of CTG, they would have recognized absence of cycling before. They would have recognized a zigzag pattern before. And if the baby's delivery is not imminent, they should have done a cesarean section, because hypoxia and sepsis, they don't go together. So let me finish with human factors. If you look at any airline industry plane crash, they have identified 12 human factors. CTG interpretation is exactly the same, especially with regard to chorioamnionitis. Most of the time, if you think about what goes wrong, is our knowledge. Because my consultants taught me when I was a registrar that there's something called uncomplicated tachycardia, just because there are no decelerations. And what did they ask us to do? They said, give water to the mother. The woman was saying, no, I have got 6 liters of water. What medical school did you go to? I've got 50% expansion of plasma volume. Why are we giving more water to the woman? So change position, as if bacteria are going to run away when you put the woman on the left lateral position. And then we were told, when I was a registrar, do something else. Antibiotics to the mother. Do fetal. Luckily in India, you don't do cutting the skin to look at bacteria. So you can see why we are failing these babies. So I'd like to thank the Stillbirth Society for inviting me. So please remember, chorioamnionitis is a fetal disease. We need to carefully observe. So if you have good progress of labor, she's a multigravida, the CTG shows normal cycling. There's no evidence of neuroinflammation, continue labor. But if you find that the labor is not going to end soon, the delivery is not imminent, there are additional risk factors like meconium and maternal pyrexia. And there are CTG showing you absence of cycling, sinusoidal patterns. On top of that, if the mother has signs of infection like pyrexia, and put other features into it. Is she a multip? Is she a primate? Is she in active phase? Is she in early phases? And take a clinical decision. But please remember, chorioamnionitis is a fetal disease. It's severe sepsis. And we shouldn't be allowing hypoxia and infection to mix. Sorry if I've overrun.
No.
So thank you very much. Any questions? I'm very happy to.
Yes, thank you, sir. It was excellent talk, all mesmerizing. And as you have less time, we will ask hurriedly whatever questions are there in the chat
That's
box.
fine. No problem.
And I'll take this opportunity to take all the questions hurriedly. So first question is by Dr. Indra. Does intracervical PG gel introduces bacteria?
So honest answer, it might. But remember, I tell my trainees all the time, if as obstetricians, if we want risk-free options, we need to buy an ice cream van and sell ice cream. In obstetrics, everything you and I do will have risks. Remember that, including forceps, vacuum. There are risks to the mother, risks to the baby. All you and I have to do is to weigh the risks and benefits and to say which is the least risky option. So if you want to induce someone, you give transvaginal or cervical prostaglandins. Yes, it's going to increase the risk of infection, but the good news is you're not going to send her home. You're going to actively intervene, and therefore within the first 48 hours before the bacteria get incubation, etc., the baby would be out. So, but in membrane sweep, what we are doing is we are doing the sweep and sending them home. And then she sometimes comes after 5 days, 4 days. And that is the problem. So yes, the honest answer is we don't know. And most likely the bacteria, anything you do with the cervical mucus, we think we are putting a sterile glove. But the bacteria is laughing because our hands may be sterile. But when you do the sweep, aren't you pushing your bacteria inside? And the GPS from the lower vagina has a good time upstairs because we take it up and leave it next to the cervix. So it's true that any manipulation, including putting an intracervical balloon catheter for induction of labor, they are all going to increase the risk of infection. But then you're not sending them home, hopefully, and you're going to induce them, augment them soon after. And therefore, within 2 days, if the baby goes, the woman goes into labor, the risk of infection is very, very low.
Okay, thank you. Now, Dr. Lata asked, how do you decide mode of delivery in thick meconium? Even thick meconium may not show fetal heart rate abnormalities. So I think you will say, yes, we have to go for a cesarean section.
Yeah, because of the time, yes. I didn't show something, but I think because the answer, they have asked this question, just give me one slide. I just want to show one slide to answer that question, which is very, very important. This one. So this is to say why, okay? Why should we do cesarean section? So in our study, we found if you don't do timely cesarean section, 94% of the time, you will end up doing a cesarean section anyway due to CTG abnormalities in late labor with poor outcome because all those 94% went to neonatal unit and 75% had a prolonged admission in the neonatal unit, and the woman came with readmission. So this study is a clinical study, but in Japan, they replicated the study in an animal model, and they showed the same thing. Even if you have infection, if you don't mix hypoxia with infection, your outcome is better. So even if you think you are doing too many cesarean section, don't worry, you're not. Because if you're not doing an early cesarean section, you will do a cesarean section later on in labor with a poor outcome for the baby. So if you have thick meconium, if you have got baseline which is 10% higher than expected for the gestational age, or absence of cycling, ask yourself, if it is your baby, what would you want to do? Would you want your baby to go to school? Would you want the baby to play netball, football, cricket? If that is the situation, give the same thing for others. So is sepsis, hypoxia and infection, they don't go together in adult medicine or neonatal medicine. It's a good question. And I'm glad you're asking it, because it's a cultural, historical bad practice that we have all trained in. We will run to the theater when we see big decelerations. But those are the babies who are telling us, leave us alone because we're having a good time. These babies are the ones, they can't show you big changes because of neuroinflammation. Their reflexes are blunted. And if you have thick meconium, early labor, ask yourself, there's a risk of meconium aspiration syndrome. There's a risk of chorioamnionitis. There's a mix of hypoxia. If it is my baby, what would I expect the obstetrician to do? Bail out. Whereas if she's a multip, she is fully dilated, coming from home, you have thick meconium, CTG shows a higher baseline, but normal cycling. You minimize the amount of active pushing, use forceps or vacuum and expedite birth. So in that case, you're not combining hypoxia and infection for a long time.
So next question, Edwin, is what is your advice regarding babies who are post-dated and having meconium in labor?
Yeah, so always remember 20% of babies will pass meconium as a because of physiological maturation of the gut as the gestation advances. But the presence of meconium increases the risk of infection. So if she is post-dates, one thing, the placenta is going to be not functioning as at 38, 39 weeks. That's one problem. So the baby starts off with an increased risk of hypoxic stress in labor. Secondly, if it is thick meconium, which means there's oligohydramnios, which means there's going to be more cord compression, and that increases the risk of meconium aspiration syndrome. If you have a deep decelerations, if you look at scientific evidence, that induces in utero gasping. So take a step back and treat each baby differently. So if you have a woman at 41 weeks coming to you, she's in established labor, she has been progressing well spontaneously, CTG shows normal, higher than expected baseline, but normal cycling, no other features of neuroinflammation, and her progress has been really good in the last 4 hours. Careful observation, continue. But if you have the same clinical situation in another woman who is stuck at 3-4 centimeters, there's thick meconium, absence of cycling, explain to her that if this is the situation now, unlike marathon running, human labor, as this time passes, the contractions are going to get longer and stronger. And if the baby is in this situation, the baby is not going to withstand late first stage or second stage. So let's bail out now rather than bailing out with a poor outcome. So post dates, consider the whole clinical picture.
So Dr. Manju has asked, what is the role of CRP? Is there any role?
CRP has a role in the antenatal period. The moment the contraction starts, CRP has no role because it's an acute phase reactant. And labor itself is an acute inflammation, as we know. It's an inflammatory process that drives labor. So CRP is very good to monitor labor in the antenatal period if you have a ruptured membranes. But once the contraction starts, forget it, you're wasting your money if you're using CRP. I'm doing a series of master classes for America now, and there they are using amniotic fluid interleukins. So probably that's the future. Interleukins in the amniotic fluid to detect infection. CRP is the maternal CRP, and it doesn't tell you much about chorio.
Okay, so Dr. Sheila asks, role of biophysical profile and absent respiration in baby.
Well, no one knows. When I was a trainee, biophysical profile was in a big way. But the problem is, once the contraction starts, there are lots of variables. If you think about you as a fetus, each contraction is different. Your cord compression is going to be different. Your amniotic fluid volume is going to be different. Your maternal environment is going to be different. If you think of all the variables that babies have, biophysical profile, it went out of fashion only because, just because your biophysical profile is high or low, it doesn't mean that you are going to go through labor without damage. The best test is your intrapartum CTG. Look for cycling, look for features of neural inflammation and hypoxia, and manage them accordingly.
So last question is from Dr. Manju, that if we clean the vagina with betadine, then what is the role of sweeping? And if we get it correct, is it correct practice to start the oxytocin to expedite delivery in patient with MSL? MSL, basically. If the
oxytocin, as you know, the current evidence is it doesn't reduce the cesarean section. It doesn't reduce operative vaginal births. The only reduction is potential 2-hour reduction in the duration of labor. So please, if you look at our report from Sweden, 68% of their brain damage cases are due to oxytocin use. In the UK, each baby counts 20% of our brain damage cases are due to oxytocin use. So please use oxytocin very cautiously. In America, after 6 centimeters, they don't use oxytocin because of scientific evidence. In the 3 hospitals I am working, I've just ordered amniotic fluid lactate machine because if the woman is not progressing, you take a bit of amniotic fluid, a drop of amniotic fluid from the vagina or bed sheet, you analyze for lactate. If the lactate is high, that is coming from the myometrium, don't start oxytocin. You give bicarbonate, neutralize the acid in the myometrium, and then you start oxytocin if necessary. So again, one of the problems we are doing now, Aruna, is that when a woman is not progressing, everyone gets oxytocin due to delayed progress. But we learned in medical school, some of them have true uterine inertia, where if you give oxytocin, it will correct the fundal dominance. But the vast majority of women, they don't have uterine inertia. They have a tired uterus because they have been in latent phase for 2 days in labor at home. So if you start oxytocin with myometrial lactic acidosis, you're going to increase the risk of postpartum hemorrhage and operative vaginal births. And there are lots of studies from Norway and Sweden showing us that if you use amniotic fluid lactate, you will reduce the risk of postpartum hemorrhage and operative interventions. So don't use oxytocin, but about betadine in the vagina, I really don't know because it all depends on the duration. So for cesarean section, it's okay, very good, because you're cleaning, you're doing the operation. But here, if you're sending the woman home, and if you have introduced a bit of, it's better than, I believe, nothing, but I don't know the answer because there's no research evidence I can give you so that it works.
Thank you, sir. It was a wonderful lecture. I would like Dr. Reva to give her comments, please.
Thank you, Aruna.
Dr. Aruna, the last question is also very important.
Okay, so the last question is now just have been posted. Do you suggest 24 hours conservative management for prompt to set into labor or immediate IOL or augmentation?
No, very good question. So please, when a woman comes to you, this is what I say in our practice, either we buy ice cream van or we engage, it's a very good question. So if someone is coming to you with ruptured membranes, do a CTG, make sure that the baseline is appropriate, there is cycling. If all is well, reasonable to offer 24 hours because about 70 to 80% of women will go into labor. So you're trying to avoid interventions. If there's no meconium, it's reasonable. But if you have absence of cycling or baseline is more than 10% for the gestational age, don't wait. Because if you send her home, the bacteria, they are only trying to multiply further and further. And we know if the bacterial load increases, babies are going to have a problem. So it's all about the load of the bacteria. It's like the current war in Russia and Ukraine. If you put more soldiers on one side, more equipment on one side, you lose the battle. Our bacterial invasion is similar. The more we have host response, but they are all limited by the load of the bacteria. It's like eating a small Kentucky Fried Chicken leg and have a mild diarrhea, and eating the whole bad Kentucky Fried Chicken whole, and then having sepsis in the ICU. It's the same. So good question again.
I think questions will never finish with Dr. Edwin. It was such a wonderful lecture and opened all eyes. So ultimate thing is CTG should be like a ECG to us. So Dr. Reva, we will like to have your comments.
Well, I think we have been hearing a completely new perspective, and it's something that we've got to get used to. And I think we need to kind of explore this in our setup, because of course, we do face problems of infection. They're obviously more with us than with the subtle changes of the CTG. We're used to all the old ones, and we've got to modify our practice to incorporate these. And I hope that a couple of years from now, we would have been able to do that. And let's see how much change it is able to make for us. It's going to be a bit of a tall task, of course, to change, but because we're still at the level of trying to get the old ones recognized, and with the limited availability of CTGs, etc. But nevertheless, you've opened our eyes to the fetal, and let's hope close to where you are in the next short future. I hope so. Thank you, Dr. Edwin, for a very wonderful lecture.
Thank you very much. And I'd like to thank Tamkin and Ayesha for kindly inviting, and Aruna for sharing the session. And good luck to your Stillbirth Society, and keep up your good work.
Hey, thank you, Dr. Edwin. It was amazing. Amazing. Everybody has written, we are glued to the screen. So it's really developed the insight. Thank you, sir.
Thank you.
Dr. Neelam.
Yeah. So first thing, we will thank Dr. Edwin for the excellent lecture. And as Aisha already said, there are such good reviews in the chat box. We are very, very thankful to you, Dr. Edwin. And the second thing is that as Dr. Reva said, this is totally a new perspective, because what we used to think was CDC said III, chorioamnionitis condition, and this, what you told us today, is totally a different thing. Like the latest Cochrane analysis also, 2020 Cochrane analysis also does not say against stripping of membranes, right? They have not compared, they have not given chorioamnionitis perspective from that big Cochrane analysis of 2020. And even the small studies like strip G and all, even in the presence of GBM, they have said. So we will have to explore today's findings, and maybe change our practices by and by. But so far, this is totally a new perspective.
Neelam, just before I go with the taxi, you're absolutely right. And if you think why most of the studies didn't show any correlation, is because we were looking at maternal pyrexia and tachycardia as the endpoints of chorio. And we were looking for CTG changes, mainly decelerations and pathological CTGs. So those are the flaws in the study, but you have made a very good point. And I hope the younger generation after us will be thinking about all these and change our practice even further.
Yeah. Yes, you're absolutely right, Dr. Edwin. I think we have to now take a few studies, maybe stripping of membranes with those neonatal things.
Yes, exactly. Yes.
Yeah, because these practices, especially in the low middle income countries and the low income countries, stripping of membranes is still will remain this mode of induction of labor. But then we have to objectively look for evidence of infection from the neonatal point of view.
I think for Stillbirth Society, this is a good project to do.
Yes.
You know, look at physiologically, and even you can look at in retrospect. And then if you have any fetal heart rate traces, compare cycling, etc., 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 and you can do it, because India, you know, you have huge, you know, the numbers. Probably that's what you could lead the world in choreo.
Yes. Yes. Thank you very much, Dr.
So thank you. Thanks, everyone. Have a good session. Sorry, I couldn't stay for the whole session. So thank you very much.
Thank you.
Thank you.
Thank you. Thank you. So now we move with our next lecture by Dr. Manisha. That is on unexplained stillbirths in labor and role of fetal autopsy. Dr. Manisha is a professor, director professor at Lady Hardinge Medical College, and is pioneer in setting up the fetal medicine unit in the Lady Hardinge Medical College. She is an avid researcher and a team leader, and she has got many research projects. And recently she has been awarded in Foxy with the, I think, CL Jhaveri Award for her research. So over to you, Dr. Manisha.
Thank you, Aruna, for the kind words. So I got the best research paper award in Foxy. So
congratulations.
And, thank you for inviting me. So whereas Dr. Edwin talked about prevention of stillbirth, in my talk, I would like to concentrate on prevention of the next stillbirth. So basically how to prevent next stillbirth once one has happened. So the talk is about unexplained stillbirth in labor and role of fetal autopsy. So basically, I would like to concentrate and be more practical and what we can do. So doable things in my talk. So in this talk and this topic, we have intrapartum stillbirth and we have unexplained stillbirth in it. And when we talk about unexplained stillbirth, many people say that nothing is unexplained. It's only that we have not explored the things. So it is rather an unexplored stillbirth. And to explore it further and to, you know, diagnose more and more cases so that reduce the unexplored stillbirth, we have fetal autopsy, which helps us in this. So I would start with a case just to explain the things. So a 25-year-old primary gravida, she came at 37 weeks gestation with labor pains. She was showing at a dispensary, had 3 antenatal visits. One ultrasound was done at 20 weeks and it was normal. So she was a low-risk pregnancy. On examination, her general condition was fair. Her BP was normal. So on per abdomen examination, baby was cephalic. She was getting good contractions, but the FHS could not be localized. So there was absence of fetal heart, which was confirmed on ultrasound. And while the ultrasound was done, an ascites was also detected, and maybe there was a pleural effusion also. So the patient and relatives were briefed about the situation. And she was in active labor. She was admitted in labor room and labor progressed. And she subsequently delivered a stillborn baby vaginally, delivered vaginally, and it was weighing 2.4 kgs. So what was the cause of this stillbirth? So when we go to ICD 10 PM classification, in which there is fetal causes and there are maternal associated conditions that we look for, in the fetal cause, we first looked at whether it was an antepartum or an intrapartum stillbirth. So this patient had come in labor, so we assumed that it was an intrapartum stillbirth, but maybe it would be just an antepartum. So we need to look at the baby. So this is the baby that we saw, and it was a fresh stillbirth. Contrast to this baby, which is a macerated cord, may be brown in color. As you can see, the cord is brown in color here, but the cord is normal color over here. So we assume in this case that it was a fresh stillbirth. And so we need to investigate the cause of death in this case. For this, the tools that we have are history and clinical examination, maternal investigations, fetal examination, and examination of placenta and cord. So we talk to the mother, generally taking good history, again, reviewing the history. In the records, we look at her age, her parity, her weight, her BMI, because these are the risk factors that can, lead to stillbirth. Then reviewing her antenatal records is very important, confirming her period of gestation, her number of antenatal visits, the blood pressure records, ultrasound records, whether there was a presence of any anomaly or not, the Liker how was it, how much was it, the fetal weight and the AC along with the centile. And if it was in labor, then CTG recording also might help us knowing what was the cause. And then the history of leaking or bleeding PV is important. So in this case, she gave history of having some bleeding since 4 or 5 days with small amount of pain also. And she just took it that because she's term and maybe she's going into labor, and she did not come, and it was COVID times also, therefore she did not come to us. So these are the investigations that we order in all women: CBC and a blood group, torch serology, VDRL test, maternal blood glucose, fasting and PP and HbA1c, and maternal TSH. There are certain specific investigations that we get done when there is certain symptoms or signs, such as if the patient is having itching also, we can get our LFT and bile acids. Then fever or PROM, if it is there, then we can get blood culture, HVS or membrane, placental membrane culture. Or if it is a FGR or placental disease, then or an unexplained death, as in this case, we might get an APLA and LAC also done, which is very essential. So as this case, there was a inking of hydrops also present. We got the ICT done and it was negative. So we thought that we might just have a look at the baby more carefully, and that is called fetal autopsy. So fetal autopsy is not that only we do an internal examination. It involves getting a photograph, an external examination, internal examination, infantogram, which is especially required if there is a skeletal dysplasia we are suspecting, or if it is an unexplained stillbirth, or if there is some birth defect present. Blood and other genetic tests are also required. And then we have to send relevant tissue for histopathological examination, and we can keep the DNA for storage after extraction. So they gave consent for only external examination. We took the consent and we examined the baby. So this was the baby. So when we are examining the baby, we take a photograph, and then the first thing that we do is the biometry. We take the OFC, that is occipitofrontal circumference. We take this, and everything that whatever measurement we take has to be compared with the nomogram. So we compared it with the nomogram for that, and we found that to be normal. Then we can take the crown heel length of the baby. So like we are taking here, the crown rump length is being taken. We can take crown rump length also, and then we can take crown heel length also. So both are generally taken. We take circumference from abdomen as well as from chest. So after this, we look at the baby from head to toe. The neck was short here, the abdomen was protuberant, and there was a hydrocele present also. The legs appeared quite pale and a little bit edematous also. The back was all normal, and we especially look at the digits, whether they are complete, whether there's any clinodactyly or not, and you look at the palate also, whether there's a cleft palate or not. So it can be present without cleft lip. So after this, we must examine the placenta, especially if it is a intrapartum death. The placenta is like a black box. It can tell you many things. So we start with the weight of the placenta, then we examine the placenta. Here we are seeing this placenta of the same baby. So when we are examining, we are going to take the dimensions also. And then what we see here is that there is a filamentous insertion of the cord. So the filamentous insertion was over here. That was telling us that this was abnormal in this case. So we examined her fetal side to see any retroplacental clot or any calcification or any large areas of infarction. So after this, we know that filamentous insertion may be associated with FGR, may be associated with congenital anomalies, preterm labor, abruption also. So after this, we send the placenta, whole placenta in formalin, in 10% formalin. That means that you have to keep in the large jar, you have to keep 10 ml formalin and then 90 ml water, and then it can be sent. So apart from that, we also save cord blood and keep it in heparin vial, EDTA vial, and red plain vial for CBC. In this case, we sent the CBC and found the HB to be 5.6. So maybe this patient had slight bleed, the baby had slight bleeding, and that would have led to hydrops. So that could be a possibility. So if we are thinking of doing a genetic test, especially if it is an unexplained stillbirth, we can send the part from here, 1 rupee coin shape thickness, whole thickness of placenta with cord, small amount part of cord can be sent, and it has to be sent in normal saline when we are trying to do some genetic test, such as chromosomal microarray. So we can do this and send the, remember to send it in Ringer's lactate or saline. So after doing all the investigations, what we found here was it was an acute intrapartum event. So it was an intrapartum, it was I3, and in maternal causes, it was complications of placenta, cord, and membrane. So this is how we worked up in this case. So apart from that, looking at the placenta, as I said, is very important. You can see here, this is a placenta with almost no turns, no coils in the cord. And here we have a placenta which is very small, and we have to see the cord insertion also. Where is the cord inserted? So if it is inserted too much in the margins, that could, so it was a baby with FGR, and this placenta was so unique, and we are doing a placental research. So this photo was given to me by the research associate who was working on this, that ma'am, this placenta looks so abnormal. And you can see there's so much hypercoiling over here. And so these things are very important that we see in the placenta, and we can send it for histopathology and find that whatever are morphological pictures there, whether it is correlating or not. Now, there has been, like, whenever we send it for histopathology, there has been standardized definitions that has come up with Amsterdam Placental Workshop Group, and they have defined everything. Which things do we call as FGR? What are the requirements? What do we mean by maternal vascular malperfusion? What do we mean by fetal vascular malperfusion? So everything has been defined, and accordingly we can see the picture. So this is a normal picture, and these are the abnormal pictures that we can see. So when I looked at the data, like 2 years data of our center, to see what was the main reasons for intrapartum stillbirth, we found that out of 21,212 deliveries, there were 610 stillbirth. The rate was 29.6 per thousand. And here we found that in the intrapartum stillbirth, M1 or the placental causes were the most common of the causes. So as I said, the placenta is very important to be seen, especially in an intrapartum stillbirth. We must look at that. Then we looked at what was the next important, and we found that the next important was M5, that is no specific cause in the mother. So you see how difficult it is when the mother is absolutely normal and the baby can have a stillbirth. We have to remember this, that this can also be a situation, and we have to just be very vigilant when the patient is in labor. So when we looked at the causes, like if the M5 is there, and what are the actual intrapartum causes? So we looked and we found that the disorders of growth were the most common causes. So the mother was completely fine. She was a low risk mother, and she had an FGR, mostly late onset FGR that led to stillbirth. And so that was the important point to look upon. So I would just like to discuss another case, and this is a very familiar case that we often, come across. And she was a 29-year-old primary gravida. She came to us at 38-week gestation with labor pains. She had four antenatal visits, and so first one was at 14 weeks. Subsequent visits were at 16, 21, and 36 weeks. On admission, her blood pressure was normal, 130/86. She was in early labor. Her FHS was 148 per minute regular. She was admitted in labor room, and labor progressed spontaneously. She was taken to be as a low risk woman. And after 4 hours, when she went into active labor, she was examined, and the fetal heart could not be localized. Absence of fetal heart was confirmed on ultrasound. So, and then subsequently, when baby was delivered, you can see just a photograph could tell us that this baby, the whole meconium smeared was smeared in her on his body. So it was 2.5 kg at 38 weeks. So at 38 weeks, when you will see the nomogram, you'll find that the 10th centile is 2495. So the baby was just at 10th centile. But when we looked at the records, we found that at 33 or 32 weeks plus 3 days, the baby weight was, the estimated fetal weight was 2.2 kg. So when you see that it was something like this at that time, but has decreased, has reduced to 25th quartiles, that is 50th quartile decrease was there. And so this fitted into the definition of being an FGR. And because it was a late onset FGR, the baby had very less reserve and maybe had hypoxic episodes, and then there was a demise. So this in this, when we go into the ICD-PM coding, we put it as disorders of fetal growth, and we put it as no maternal condition. So what is the utility of fetal autopsy? It adds to the diagnosis in 30 to 50% cases. It is an audit for the quality of antenatal ultrasound also, because especially in our part of the world where the ultrasound is not done very well, many a times, like in our study also, we found there were additional things that we could see on autopsy that we could not find on ultrasound. It aids to the diagnosis of counseling regarding the risk of recurrence in future. And then it also tell us what should be done even when the cause is obvious. Like even if there is an obvious cause of stillbirth, we can go in for autopsy just to confirm. So that in this case, in which there was hypoxia, the placental histopath showing hypoxia would confirm the diagnosis. And to the healthcare providers, we must discuss the option of full autopsy or even the limited postmortem. So I looked at the literature to find some new literature on the subject and found that very interesting article, Predictors of Autopsy Following Stillbirth in Queensland, Australia. That was a population-based study. They found that the couple, although they might say decline, like getting an autopsy done, but they still desired to know the reason why the baby was stillborn. And parents' knowledge and understanding of autopsy process was acquired primarily from the public discourse, that is from dramatized television programs. So maybe they had all that post-mortem things in mind. That's why they would have refused. And declining a perinatal autopsy rates in a general public was, there was a declining rate that was perceived in that the study that they did. And the clinician attitude was also an important factor why it declined. So they say that there is a blame, there is a guilt in the couple or in the women, and that also gets, the closure takes place once we find the cause, such as in the first case. Like once she knows that, okay, this problem was there in the baby, the placenta. So that was the reason why my baby did not survive. So women who receive and understand autopsy results were less likely to self-blame and may feel some absolution of their antenatal actions. And it provided with emotional closure. And they also suggested that there could be some less invasive techniques that could be done if there is a refusal. They also looked at what was the reason when they consented for autopsy. And they were mainly primigravidas, those with congenital anomalies and those with antepartum stillbirth. Because they probably got time to understand the nature, and they got time to think and get over that loss, and to think that we should find out the reason. Conditions where the autopsy was declined was mainly an intrapartum stillbirth or an unexplained stillbirth. So when we started looking at the literature, we thought of doing some study, and we looked at why there is low rate of autopsy, basically because we as physicians are not convinced about its value. And parents' refusal to allow investigation is basically because they are unprepared. It is not communicated to them properly. The request is declined due to grief and bereavement at that time. Allowing babies to be taken to a pathologist may not be acceptable to them, and due to their religious beliefs. And they also wanted baby back for their last respect. That was the main reason. So we thought, what could be the way out? we could counsel these patients in the antenatal period itself that you need baby's examination and it is essential and you must get it done and we will return back the baby to you. So this was what we started doing, and we thought we would start doing autopsy in the labor room itself. And we also had a thesis on this subject, and we did it. So we just could hand the baby back to them on time. And many of the cases we did just an external examination when they did not, and I could see the satisfaction in their faces. So the consent was readily given, and it would increase satisfaction that yes, they went for this termination because of the anomaly, and then it was proved. So that gave a satisfaction to the couple also. So this was a paper that we had, it was in 2015 that we published. So it was a 4-year study in which we looked at the relevance of labor room fetal autopsy and increasing its acceptance. So when we compared our result, we did 312 autopsies. So they were partial also. We could confirm in 63.5%, quite comparable to the other studies. And we added findings 24.7%. And there was change in diagnosis in 11.8% of the cases. So I also looked at other studies and found that they say that less invasive autopsy was also a choice that should be given. So what are the methods that we have in less invasive autopsy? We have CT imaging that has been suggested, and especially if there is a bone defect, then it helps a lot. Then there is an MRI which could be done, but there's a limited availability. It has got not very good sensitivity, but the specificity is very high. And then there is minimally invasive tissue sampling also that could be done, especially to have a biopsy of liver if it is a storage disorder disease, or if we want to do biopsy from kidneys if there's a renal disease. So even an external examination is a very good option, just to bring forth this point. I remember there was a case in which when we asked the patient, what happened to your previous baby? She said the baby had hydrocephalus, or some large head. So when I asked her what was it a male or a female? So she said it was a male. So I asked her, what about the thumb? Was it flexed? So she said, yes, I remember I have a photograph. I will share the photograph with you. So this was a photograph of the baby which she shared. So when we look this, you can see the adducted thumb, the male baby. So we knew that it was an X-linked hydrocephalus. So this patient had come next time, she had come at around say 13, 14 weeks. So we asked her to just wait and come again. So at around 17 weeks when she came, there was mild hydrocephalus. And when we looked at an ultrasound, we saw that there was adduction of thumb. And so we counseled her, because in mild hydrocephalus, generally you don't terminate. But once we got 2 things which were similar, and the history also, we were sure that this was also an X-linked hydrocephalus recurring. Because it is X-linked, the chances of recurrence is 50% in the males. So it is not that we cannot do. Whatever we can do, we must try doing. So I've particularly kept this thing in the last. What is the ACOG FM guidelines, recent guidelines regarding what to do, what investigation to do in a stillbirth? So if you just look here, if there are no clinical clues, you go for genetic testing, antiphospholipid antibody testing, maternal fetal hemorrhage. So in every case, in whatever situation you are, you need to do fetal autopsy to get the placental pathology. It is an intrapartum stillbirth. You do antiphospholipid testing, you do fetal maternal hemorrhage testing, and other testing as indicated. And then you always do a fetal autopsy, and it is always, advised that we must do whatever we can. We must try and do, and we must be first convinced that it helps. So thank you all for patient hearing.
Thank you, Dr. Manisha. It was an excellent lecture, and I work with you. I really know your passion, and it was really amazing lecture, and it is a very important part. So 2 parts today we have covered. One is the fetal autopsy that has to be done whenever we can do, and the other thing is the CTG interpretation. So let me see if any questions are there. So I think everything is clear. So as such, one Dr. Smriti, I think, had asked that do we need anything special permission for performing the autopsy?
Yeah, normally in SGPGI, what we used to do is like we had a consent form, typed consent form, which we used to, get filled. So in our thesis also that we had given to PG, we had a similar kind of consent form. But yes, that consent form is enough. And nowadays, like we send it to pathology department. So there also there is a 2-page consent form that is being filled. So and that's it. And there is no as such. So we return back the baby to them. So if we want to keep the baby, then that would be a different consent that would be necessary. And the consent involves using photograph of the baby for, publication purpose also.
Okay, thank you. It was this lecture only. So we finish with
Aruna,
this.
may I make a comment?
Yes, ma'am.
Okay, what I want to make, of course, Manisha's lecture is always very good. I've heard it before, and we know that Manisha has been doing very good work. I would like to make 2 suggestions to the Stillbirth Society. One is that maybe some kind of workshops could be organized so that, and Manisha could take the lead in that, to demonstrate how a autopsy should be conducted, both the full-fledged autopsy as well as these mini autopsies. So that's one suggestion. And another is, I think that the Stillbirth Society could also, or the members, I mean, I'm not talking about the society consists of members, so they should try to increase their autopsy rates. And if we can audit our autopsy rates and document and increase, I think the Stillbirth Society will have served a very, very important purpose. So my request to all the members of the society, and as well as all the office bearers, to please think on these lines. And I'm sure that Manisha will be happy to conduct these workshops also.
Sure.
Thank you.
So with our pathologist, we can do it.
Thank you so much. If I can just say a few words, Dr. Thank you so much for this excellent suggestion. And I'm the way Dr. Manisha had shown the video, that made a lot of difference to the actual way of examining and training others. So I think that's a very good suggestion, and I request all society members, whatever the part of SBSI committee they are part of, they can hold webinars, they can hold workshops on their own. Only thing is that they will just put one slide there that it is being held under the aegis of SBSI. So all of us are a team, and any one of us can take the lead.
Yes, ma'am. Definitely we should be doing, and we should be continuing with our continuous medical education. Now I would like to invite Dr. Neelam Aggarwal to say a few words and then Dr. Aisha for vote of thanks.
Thank you so much. Manisha, your lecture was excellent as always. So just a few, 1 or 2 clinical practice pearls I would like to emphasize, that unless we obstetricians, we are convinced ourselves that placental examination as well as fetal autopsy will yield us some cause or risk of recurrence, and it is an useful examination. Till then, we cannot convince the parents, and it's very of course, it is in practice difficult for parents to give consent for autopsy. But if we are convinced ourselves and we counsel them that if this examination may give you an answer for your next pregnancy prognosis, this is very important. Most of the parents, they may, right? So that is one thing that we should convince them. Compassionate counseling at that time is very, very important. And with especially for the future, if you tell them the benefits of this examination for the future pregnancies, most of the parents will agree for this. And second thing is that we need to have experienced perinatal pathologists, but it is not difficult. There are some perinatal pathologists already available, and they can train the other pathologists. But the interest and the will has to be our own. Thank you.
Thank you, madam. Really, these were the nice words, and you had a take-home message for all of us. And we come to the end of session. Although I have written I want to say, because I have made this course with lot of efforts on the CTG basic to advanced, and I'm passionate about CTG because we can interpret the CTG and see the prognosis of the fetus. So that is very important. That's why I, with Dr. Aisha, decided to call Dr. Edwin. So if you get a time to please go through the CTG basic to advanced, which has got 16 video lectures with exercises and with our own CTGs, with the clear situations. It's not a computerized CTG taken from any book. So please go through it, all the postgraduate, develop the concept. It is not only just to say it early deceleration, late deceleration. This is not done, because these are the situations which we can miss. We have to interpret each and every component very clearly, so that to give the best outcome of the baby, which is very important. It is not the immediate outcome. It is the next 5 days of an ICU admission. It is the next 2 years of the milestones which is needed and which we need to interpret. So that is the thing I request all of you to, if you can get a time to see that. And at the end, I would like to ask Dr. Aisha, who has made all the efforts to call Dr. Edwin. Really, Dr. Aisha, thank you for putting in this effort and give a vote of thanks.
Thank you so much, ma'am. So, ladies and gentlemen, it's been a great honor to be presenting the vote of thanks for today's CME. And I would like to thank Professor Aruna Nigam for the meticulous planning and execution of the webinar. Thank you, Professor Reva Tripathi, for gracing the occasion with your presence and serving as chair for the webinar. It's been a wonderful evening, and we have witnessed 2 extraordinary speakers delivering their talk. Mr. Chandraharan is not here, but I would like to thank him for agreeing to take time out of his extremely hectic schedule and making us all aware of the intricacies of chorioamnionitis detection with this wonderful presentation. And I would like to thank Dr. Manisha Kumar for her crisp presentation and amazing delivery of the message. And let me say, those videos were so empathetic, so wonderful. And most importantly, I would like to thank Professor Neelam, Dr. Nuzhat, she's not here today, Professor Tamkin, and Dr. Asna for their constant support and making all these webinars, newsletters. And I would request, please, everyone, please send articles for the newsletter. So we have different newsletters for every month, and different societies, they conduct their webinars. We would welcome case reports, your experiences, maybe even a short poem for those who are poets, maybe even a drawing, an art, anything. We would welcome them. Thank you so much.